All right, welcome everyone. We're kicking off a two-part explainer diving deep into the structures that run the show in the middle ear. Today, we're going to focus on the eustachian tube, what it is, what it does, and its absolutely critical role in regulating pressure. Then, in our next session, we'll tackle the mastoid air cell system.
So, here's the plan. We'll start by breaking down the elegant mechanics of a normal adult tube. Then, we'll get into why kids are just so prone to ear problems. After that, we'll look at the whole cascade of disease that kicks off when the system fails, and we'll wrap it all up with the key clinical takeaways you need to know.
Okay, let's dive right in. The eustachian tube, or ET for short, you could argue it's the single most important structure in all of otology. Seriously, because when this little tube doesn't work right, it's the root cause of the most common ear diseases we see. I want you to think of this tube as the middle ear's personal pressure regulator. See, the middle ear is basically a little air-filled box, and the air inside is constantly being absorbed by the tissue lining it. So the ET's main job is to pop open for just a fraction of a second to let a tiny puff of air in from the back of your nose. That replenishes the absorbed air and keeps the pressure on both sides of your eardrum perfectly balanced. Now, what's really fascinating here is how the tube opens. It's not just some passive flap, it's an active muscular process driven almost entirely by one muscle, the tensor veli palatini, or TVP. Every time you swallow, the TVP contracts, and as you can see here, it yanks the soft wall of the tube open for a split second. Air rushes in, the system resets, and it all closes up again. This happens 1,000 times a day, and you never even notice it. Okay, so that's the elegant system in an adult. But here's the twist. That system is fundamentally different, and honestly, way less effective in children. And this right here, this is the key to understanding why ear infections are just rampant in childhood.
And this table just lays it all out perfectly. The adult tube is long and it's steeply angled, kind of like a well-designed drain pipe. But in a child, well, it's about half the length, it lies almost totally horizontal, and the cartilage that supports it is a lot softer. The easiest way to remember it is that the pediatric ET is just shorter, flatter, and floppier.
So, we've got these three big differences, right? It's shorter, which is a shorter runway for germs. It's floppier, so it's not as good at popping open. But which one of these is the real troublemaker? What's the main culprit behind all those childhood ear infections?
It all comes down to the angle. That's the crucial point. In an adult, that 45-degree slope means any fluid in the middle ear just drains effortlessly down into the back of the throat, thanks to gravity. But in a child, that flat horizontal tube has no help from gravity at all, so fluid just sits there stagnant, creating this perfect warm little swamp for an infection to brew.
So now that we have the anatomy down, we can really connect the dots to the pathology. Let's trace the step-by-step cascade of exactly what happens when this whole ventilation and drainage system just breaks down. It really does all start here, with eustachian tube dysfunction, or ETD. This is the first domino to fall, and it can happen for a few reasons. Maybe the lining is inflamed from a common cold, maybe they're swelling from allergies, or, especially in kids, it could be physically blocked by enlarged adenoids. Remember that sealed, air-filled box? Well, if the ET can't open up to let more air in, the body just keeps absorbing the oxygen from that space. And what happens when you remove air from a sealed box? You create a vacuum. The pressure inside the middle ear starts to drop way below the atmospheric pressure on the outside. And this vacuum effect, it's an incredibly powerful force. When you combine that with the fact that fluid can't drain out, it sends the middle ear carrying down two very distinct but related paths of disease. So on one path, the vacuum literally starts pulling fluid out from the surrounding tissues, filling up the middle ear space like a flooded basement. On the other path, the outside air pressure, which is now totally unopposed, just smashes the eardrum inward, causing it to stretch and eventually collapse on itself. This first outcome, the effusion, is what we all know as otitis media with effusion, or more commonly, glue ear. That thick, gunky fluid basically muffles the eardrum, preventing it from vibrating properly. This makes it a leading cause of conductive hearing loss in children, which, of course, can mess with their speech and language development. The second outcome is atelectasis, which is this structural collapse of the eardrum. It gets sucked so far back that it can actually start to wrap around the tiny structures inside the middle ear. And if you don't fix the underlying pressure problem, this retraction is the gateway to much more severe complications down the road, like cholesteatoma. All right, let's bring this all home. Let's distill everything we've talked about down into the most critical, high-yield points that you'll want to remember for your clinical practice.
So here's a huge clinical pearl. We often jump to decongestants for that stuffy ear feeling. But true eustachian tube dysfunction is very often a mechanical problem, not just an inflammatory one. That's why encouraging patients to do things like a gentle Valsalva maneuver, plugging their nose and gently blowing, can actually be more effective because it physically forces the tube to pop open and reset the pressure.
And what's really cool is we can actually see this problem objectively. A type C tympanogram is the classic sign. It shows that pressure peak way down in the negative range, and it's the definitive proof that the ET is failing to do its job. It often confirms our diagnosis before any major fluid or retraction even gets a chance to develop. So to bring it all together, we've seen that the eustachian tube's whole job is ventilation and drainage. We know that process is actively powered by the tensor veli palatini muscle. We know in kids the tube is shorter, flatter, and floppier, and that flat angle is the real villain because it knocks out gravity-assisted drainage. And finally, we know that all this dysfunction leads to a vacuum, which either fills the ear with fluid or causes the eardrum to collapse. When you boil it all down, it is simply this: a failure of this small, elegant tube to perform its one crucial job of letting air in. If you can understand this single concept, this logical cascade from a simple mechanical failure to widespread disease, then you have the foundation for understanding, diagnosing, and managing some of the most common conditions in all of medicine.
All right, so now continuing with the mastoid air cell system and the facial nerve path, we're moving just behind the middle ear into a region that is, and I can't stress this enough, absolutely critical for both understanding disease and for any surgeon operating in the area. Go ahead and feel that hard lump of bone right behind your earlobe. It feels totally solid, right? Like a solid piece of your skull. But that is just a disguise. Because hidden inside is this incredible, complex world, a honeycomb of tiny, air-filled chambers that connect directly to your middle ear and protect some of the most vital structures in your entire head. So how in the world does this spongy, air-filled bone even get there? Well, the process is called pneumatization, and it all starts from the middle ear space itself. You can think of the mastoid as a kind of air reservoir, an extension built to help buffer any pressure changes. But here's what's really fascinating. How big and complex this network gets is wildly different from person to person. When we're born, this system barely exists. We start out with just one big air cell called the mastoid antrum. Then, all through childhood, this amazing process happens, where the bone gets hollowed out, creating this whole network of air cells, and this results in a whole spectrum of outcomes. On one end of that spectrum, you get a well-pneumatized mastoid. It's delicate, like a honeycomb, with hundreds of large, thin-walled air cells. And on the complete opposite end, you can have a sclerotic mastoid, which is just dense, ivory-like bone with almost no air cells at all. So the big question is, what determines where you fall on that spectrum?
Well, it really boils down to two main things: your genetics and your health as a kid. It turns out that having a lot of middle ear infections during those critical years of development can actually stop pneumatization cold. The inflammation just halts the entire process, leaving you with a solid, sclerotic mastoid for the rest of your life. And this variability is exactly what makes navigating this area so incredibly challenging for a surgeon.
For a surgeon who needs to get in there, this variable anatomy is a huge problem. But there is one constant, one North Star they can always rely on: the mastoid antrum. It is the one air cell that is always there, no matter how pneumatized the rest of the mastoid is. Finding it is goal number one of any mastoid surgery. And to find that antrum, surgeons look for a critical landmark right on the surface, which is Macoin's triangle. Once a surgeon finds that spot, the next vital question is, how deep do you drill? And this is where precision becomes everything. This is just a brilliant example of why anatomical knowledge is so critical. In an adult, the antrum is about 12 to 15 millimeters deep from that triangle. But, and this is huge, in a 2-year-old child, it's only 5 to 8 millimeters deep. Getting that wrong can be catastrophic because of the delicate structures that lie just beyond it. And speaking of delicate structures, let's talk about one of the most important and most vulnerable: the facial nerve, cranial nerve 7. After making a sharp turn, the nerve just plunges straight down vertically through the mastoid bone. It runs just in front of and medial to a landmark called the digastric ridge. Surgeons use this ridge as their guide to find the nerve and, more importantly, to protect it. That relationship is literally a surgeon's lifeline to prevent causing facial paralysis. And here's a clinical pro for you.
Please like and subscribe for more custom medical videos made just for you.
Now, moving on to the next segment. Okay, so we've got this incredibly complex system of air cells, and we have a critical nerve taking a perilous path right through it. So what happens when this hidden world goes terribly wrong? Well, that brings us to mastoiditis.
Acute mastoiditis is an infection of these very air cells, and it's almost always a complication that stems from a middle ear infection. But let's be crystal clear, this is not just a bad ear infection. This is a true surgical emergency.
Here's the path to catastrophe. The small passageway connecting the middle ear to the mastoid gets swollen shut, trapping infection inside the mastoid system. The pressure starts to build, and then a terrifying process called coalescent mastoiditis begins. The infection literally dissolves the thin, bony walls between the air cells, turning it all into one giant pus-filled cavity. So with all the internal walls gone, that trapped infection is looking for an escape route. It can break through the outer bone, forming an abscess behind the ear. It can track down into the neck. Or, and this is the most dangerous scenario, it can erode inwards, toward the brain. It can infect the sigmoid sinus, that's the major vein draining the brain, and cause a life-threatening blood clot. Or it can spread directly into the skull and cause a brain abscess. Which really leaves us with a final thought-provoking question that ties all of this together. Given how dangerously close the mastoid is to the brain, how would a surgeon's approach have to change between operating on a wide-open, honeycombed pneumatic mastoid versus a solid, dense, sclerotic one where all the normal landmarks are gone? It's really something to think about.